All right. Welcome, everyone, for the Global Academic Radiology Education Program. I'm Dr. Janardana Panatapura, JP. I'm one of the cardiothoracic radiologists at Wake Forest University School of Medicine. So I'll be, just for the new attendees who do not know about AREP, just a very brief introduction. So the Academic Radiology Education Program, this is a nonprofit initiative which is aimed at providing high-quality radiology education to colleagues worldwide. So we established this in October 2021, and it is based at the Department of Radiology at Wake Forest University School of Medicine. We offer free online education resources and live webinar featuring academic radiologists from leading US institutions. This program is designed to bridge education gaps, particularly for radiologists in resource-limited settings, by sharing expertise and fostering global collaboration. We host bi-monthly webinars from January to October, and we cover various radiology subspecialties, which are well attended with up to 700 participants per live event and include contributions from esteemed institutes. And our reach extends to radiologists in different countries in Asia, Africa, and Middle East. This program's success is driven by the dedication of its committees, moderators, and speakers who work tirelessly without external funding. In addition to webinars, we also offer projects like Radiology Excellency Program, which focus on mentoring and specialized radiology challenges in various countries. So again, welcome all for another great session. So we are started. This is one of the three hot topics in radiology, the last three hot topics in radiology. So today will be a great session, and our session is moderated by Dr. Trifonia Pingan Sirigar. Dr. Sirigar is an assistant professor in Department of Radiology and Abdominal Radiology Division in University of Indonesia. So thank you so much, Dr. Sirigar, and back to you.
Okay, thank you, JP, and good morning and also good evening to all of you who joined this Zoom meeting today, this webinar. Welcome on board. And today we will have an excellent speaker, Dr. Usha Jayagurunathan. She is an abdominal radiology consultant from the Wake Forest University. Hi, Dr. Usha. You're still mute.
Oh, hello, Dr. Shrika. Can you hear me?
Hello, good morning. And Dr. Usha will give a talk about the imaging of ovarian cancer. And as Dr. JP said, for all the attendees who wants to give a questions to our panelists, please you can type the questions on the Q&A box, and we will discuss the questions on our Q&A sessions after the lecture. And now, without further ado, I invite Dr. Usha to give the lecture.
Thank you. Good morning, everyone, and good evening as well. So today we'll be talking about imaging in ovarian lesions with focusing on ORADs. So ovarian adnexal reporting and data system is an evidence-based clinical support system which was published by the American College of Radiology. So it has both ultrasound and MRI components. And the ultrasound component was initially published in 2018. It was with the support of American College of Radiology, excuse me, a group of experts in radiology and gynecology from Europe and North America. They developed the descriptors, the lexicon, and the risk stratification system. And the MRI component of ORADs was published in 2020. And we have the initial version of MRI ORADs. So why we need ORADs? We know like adnexal lesions are commonly encountered in everyday clinical practice, and we need a system to accurately diagnose and stratify the lesions for further management. So we apply the ORAD's classification system in women of average risk. We don't include patients presenting with acute symptoms or patients with higher risk, such as the germline mutations, etc. So the ultrasound and MRI ORAD's system, these are separate but have complementary lexicons and assessment categories, which we will be discussing in detail in the following slides. So our objectives today are to review the ORAD's ultrasound categories, the ORAD's MRI categories, and with that knowledge base to accurately diagnose benign lesions, to assess the risk of malignancy in suspicious lesions, and triage patients for optimal further management so that we don't have unnecessary follow-up or overtreat benign lesions, and give patients options for conservative management if they want to preserve the ovarian function. So imaging, we do ultrasound. Ultrasound is the initial imaging modality. It has a high sensitivity for detecting malignant lesions. And MRI is a useful secondary test as a problem-solving adjunct tool. It has robust soft tissue characterization and adds higher specificity for malignant lesions. So both MRI and ultrasound ORADs have lexicons that categorize an Excel finding as physiologic or as a lesion. Physiologic observations in both ultrasound and MR include follicles and corpus luteum. Other than this, the rest of all the ovarian adnexal lesions are classified as lesions. And unilocular cyst is a term included in both modalities. The term bilocular cyst was introduced in the 2022 ultrasound ORADS update. And multilocular cyst is one which has more than 2 locules in ultrasound and more than 1 locule in MRI. And coming to the solid component, in ultrasound, any focal thickening or a solid tissue protrusion of the wall or septation more than or equal to 3 millimeters in height is defined as a solid component. And we also assess vascularity, which is graded with a color score from 1 to 4. And a solid appearing component is one which has a solid appearance but no internal vascularity. And in MRI, the solid component is described based on enhancement. And we use specific descriptors to describe the morphology, such as a mural nodule, papillary projection, irregular septation, or a large solid portion. Other solid components that do not show enhancement are blood clots, avascular debris, non-enhancing, thin, smooth septation, and dermoid components such as fat. And a solid lesion in both ultrasound and MRI is one which has at least 80% solid tissue. So now comparing the risk of malignancy in both in ultrasound and MRI, in ORADS category 1, we see the risk is the same in both. It's almost like 0. And 2 and 3, it's almost similar, a little. But in 4 and 5, the risk of malignancy when we compare ultrasound and MRI, it's higher in MRI. And ORADS 5 category has a very high risk of malignancy. So that increases the specificity and positive predictive value. So now coming to ORADS ultrasound categories. So this is a ACR document published in 2022 version ORADS ultrasound assessment categories. So as we can see on the left side, there is a scoring system from 0 to 5. So we have 6 categories, and each category has a associated risk of malignancy and other descriptors, which we see here, and a management option for each of these categories, and which is divided into pre and postmenopausal status. A brief thing about the color scoring. So we have a color score from 1 to 4. It is a subjective assessment of color Doppler flow within the lesion. It can include the wall, septation, or the solid component. A color score of 1 is no flow. As we can see in the schematic diagram, there's no flow here. A color score of 2 is minimal flow. You can see minimal flow in the septation solid component. Moderate flow is assigned a color score of 3, and a very strong flow is a color score of 4. So ultrasound ORAD's 0 category. So this is the first risk assessment category, which includes incomplete evaluation due to technical factors, bowel gas, or large size of the lesion which is outside of the field of view, and location of the adnexa, inability of the patient to tolerate endovaginal imaging. So what do we do in these cases? So either we get a repeat ultrasound if it's due to technical factors, or we go for an alternate imaging modality such as MRI in selected cases. And ultrasound ORAD's 1 category includes the physiologic category. This is applicable only in premenopausal women. Under this physiologic category comes a follicle, which is a simple cyst less than or equal to 3 centimeters, and corpus luteum, which is a thick-walled cyst, which is the follicle after ovulation has happened. And the size criteria for this also is less than or equal to 3 centimeters. And the morphologic appearance can be variable. It can have an inner crenulated margin. There can be internal echoes. And there is always intense peripheral vascularity around this corpus luteal cyst. Sometimes the corpus luteum may appear hypoechoic without a cystic component. So for these lesions, no additional imaging or follow-up is necessary. So here we have a pictorial representation. On the left, we have the descriptors described by the ACR, and the schematic here, and the grayscale images in the middle column, and the color Doppler images on the third column. So as we can see, a follicle is a simple cyst. An ultrasound, how we describe a simple cyst, is a unilocular anechoic cyst with imperceptible wall through transmission, which is a posterior acoustic enhancement, as we see here on the grayscale image. And the size criteria here is less than or equal to 3 centimeters. And a corpus luteum, it's a thick-walled cyst, and we can see the descriptor here, the inner crenulated margin. The cystic component can have internal echoes, as we see here in the middle image, and there is peripheral robust vascularity. The other appearance, which is like without a cystic component, it can be hypoechoic, but we know that this is a cyst from the posterior acoustic enhancement we see on the grayscale image, and the lesion has peripheral vascularity. So this category applies in premenopausal women, and no additional follow-up is needed for these lesions. And there's a 0% likelihood of malignancy in these lesions. So some more additional imaging examples of a corpus luteal cyst. Again, this is a fairly thick wall cyst with a relatively smooth inner margin. There's internal echoes, but without any vascularity and peripheral vascularity. On image B, it's a similar cyst with the crenulated margin. Image C here shows a very anechoic cyst, but with peripheral vascularity. Again, a corpus luteum with a solid appearing component, but there's no vascularity, and that's a retracting clot because it has a concave margin here. And on this image, again, a hypoechoic lesion with posterior acoustic enhancement and peripheral vascularity, and a similar lesion here. Now coming to ultrasound ORAD's 2 category. These are almost certainly benign lesions with a less than 1% risk of malignancy. Here we include all the unilocular cysts which are less than 10 centimeters. The unilocular cyst can be a simple cyst or a non-simple unilocular cyst with smooth wall. And additionally, we also include the classic benign lesions which are less than 10 centimeters in diameter. So what are these lesions? Simple cyst, which is more than 3 centimeter, but less than 10 centimeters in premenopausal women. And any simple cyst that's less than 10 centimeter in postmenopausal women. So these are included in ORAD's 2 category. We'll look at the classic benign lesions in the next slide. And unilocular, but a non-simple cyst. When we say non-simple, it means the internal content of the cyst. It's not anechoic. There can be internal echoes, as we see here on this image, or there can be an incomplete septation. However, the wall is smooth. It's not irregular. So the classic benign lesions are those lesions which can be accurately diagnosed when one or more specific ORAD's descriptors are seen. without any concerning features. So under this category, we included are the typical hemorrhagic cyst, dermoid cyst, endometrioma, parovarian cyst, peritoneal inclusion cyst, and hydrosalpinx. So the lexicon, like the description for these classic benign lesions, for a typical hemorrhagic cyst, we either see a reticular pattern and a retracting clot. The reticular pattern should not be confused with the septation because these are incomplete and these are hyperechoic lines that represent fibrin strands. And the size criteria for here for the hemorrhagic cyst is less than or equal to 5 centimeters in premenopausal women. And if it is more for those lesions, no follow-up is needed. If it's more than 5 but less than 10, a follow-up in 8 to 12 weeks is recommended. A retracting clot is seen as an avascular echogenic component with angular, straight, or concave margins and no vascularity in that component. And a typical dermoid cyst, the descriptors here are hyperechoic component with acoustic shadowing, which represents the fat or calcium in the lesion. Hyperechoic lines and dots that represent hair within the lesion. Or floating echogenic spherical structures, which are again fat components. And a typical endometrioma is a cystic lesion with homogeneous low-level echoes or so-called ground glass appearance. A simple parovarian cyst is a cyst that is separate from the ovary, and it typically moves independent of the ovary when pressure is applied by the transducer. And a peritoneal inclusion cyst, the definition for this is it follows the contour of the adjacent pelvic organs. It does not have any mass effect and typically contains septations. The ovary can be seen either at the margin or within the lesion. And hydrosalpinx is a typically elongated lesion with incomplete septation and endosalpingeal folds, which are small projections around the inner wall of the lesion. So looking at the imaging examples, so in the first row, we have the typical hemorrhagic cyst with a reticular pattern. The schematic here shows a reticular pattern. You can see the echogenic lines that does not go all the way throughout the lesion. So these are incomplete, and that's how we differentiate this from the septation. And then this is a retracting clot. It appears solid, but you can see the concave angular margins. And on color Doppler evaluation, there's no flow. There can be some flow along the periphery of the hemorrhagic cyst that could be from the compressed normal ovarian tissue. And a typical dermoid cyst, it's a hyperechoic component with shadowing, shown here on the schematic. The lines and dots that reflect hair components. And this is a grayscale image showing the hyperechoic component with shadowing. And we see here the lines, hyperechoic lines and dots. And the floating echogenic components within a cyst is a very rare representation, but when we see this, this is pathognomonic for a dermoid. A typical endometrioma, again, it's a non-simple cyst, but it has posterior acoustic enhancement and has homogeneous low-level echoes. And on color Doppler, you don't see any vascularity within the lesion. Again, a parovarian cyst is a cyst that is separate from the ovary. As we can see, the ovary is separate here, and the simple anechoic cyst here. And it moves separate from the ovary with pressure from the transducer. And an example of a peritoneal inclusion cyst, it conforms to the shape of the peritoneal cavity. The ovary can be seen within or along the margin of the lesion. It has septations. And hydrosalpinx, again, it has an incomplete, it's an elongated tubular. When we say elongated tubular, it is longer in one dimension compared to the other two perpendicular dimensions. And it has an incomplete septation, and we can see the on cross section, the endosalpingeal folds. So some more examples of typical hemorrhagic cysts. We have grayscale images on the top row and color Doppler images on the bottom row. So we can see the fibrin strands as well as a retracting clot with the concave margins. Again, it's more of a clot with the fibrin strands, retracting clot with concave margins here. Similar examples, but there's no vascularity in the echogenics component. Typical dermoid cyst, again, hyperechoic component with shadowing and linear echogenic lines and dots. Again, we see the linear echogenic lines, a hyperechoic component. This is a mixed echogenicity lesion with hyperechoic component along the superior aspect of the lesion that represents at the fluid level, which is the floating fat. Yeah, and this is again a similar lesion with echogenic component, echogenic lines. Very subtle like echogenic component, but with shadowing and floating echogenic components within a cystic lesion. And now coming to the typical endometriomas. So the lesion demonstrates on the top row, we have the grayscale images in A and B showing homogeneous low-level echoes. With color Doppler and image C, there's no internal vascularity. Endometriomas can be multilocular and the septation or the can demonstrate vascularity. This could represent like two adjoining endometriomas with intervening ovarian tissue. So this is still categorized as ORADs too. And sometimes we can see peripheral punctate echogenic fossa in an endometrioma. These are very specific for endometriomas, and these represent the cholesterol deposits as a byproduct of hemosiderin from repetitive hemorrhage, and there can be twinkling artifact associated with the echogenic foci. Coming to ORADs category 3. This is a low risk category. The risk of malignancy is 1 to less than 10% here. And under this category, we have simple cyst, unilocular, or bilocular cyst. So as we saw, the bilocular nomenclature was updated in the 2022 version. It can be simple, non-simple cyst, and all the classic benign lesions, but the differentiating feature here is the size. So all these are greater than or equal to 10 centimeters. And any unilocular cyst, it can be of any size with wall irregularity. And multilocular cyst less than 10 centimeters with a color score less than 4. And avascular solid or solid appearing lesions with a smooth external contour of any size. So here we have unilocular cyst, multilocular cyst, and solid lesion. So there are 3 lesions that has to be kept in mind. So here are examples. So for unilocular or bilocular cyst, the size is the criteria here, more than or equal to 10 centimeters. And it can be simple or non-simple. And an additional suspicious feature which we see in a ORADs 3 lesion is a wall thickening. So this irregular wall thickening should be differentiated from a solid component because this is like less than 3 millimeters in height. It can be seen as a focal thickening in the wall. And coming to multilocular cyst, for multilocular cyst in ORADs 3, the size criteria is used and the color score is used. So there's multilocularity, like more than 2 septations. There can be a vascularity in the wall or septation, but it should be less than 4. It's like can be either none, minimal, or moderate, but no solid components, and size is less than 10 centimeters. And there are 2 categories of solid lesions here. For solid lesions, we are looking at the outer contour of the lesion. It has to be smooth, with or without shadowing, with a color score of 1 or 2 to 3. Again, ultrasound category 4. These are intermediate risk category lesions with 10 to less than 50% risk of malignancy. Here, the multilocular cysts have a size criteria that's greater than or equal to 10 centimeters, and they have suspicious features. So in ORADs category 3, unilocular cyst had a suspicious feature, which is irregular wall thickening. In 4, the multilocular cyst starts to have the suspicious features. When I mean suspicious features, it can be a wall irregularity or thickening, or a solid component, which is like a papillary projection, or a higher color score, and a size greater than or equal to 10 centimeters. And a smooth solid lesions with a color score of 2 to 3. Papillary projection is included in unilocular cyst and ORATS category 4. So papillary projection is a solid component that is greater than or equal to 3 millimeters that arises from the cyst wall, septation, and protrudes into the cyst cavity. This is as opposed to the irregular wall, which is less than 3 millimeters in height. So as we said, we have two categories of multilocular cysts without solid components, smooth inner wall. One suspicious feature included here is a size more than or equal to 10 centimeter and a color scored less than 4. Or it can be of any size, but a color score of 4. So these two are ORATS 4. And the additional criteria in a multilocular cyst, we see here's a wall irregularity or septal irregularity. When you see that, the color score or size does not matter. Or a bi or multilocular cyst with solid component. And here, when we see more of a solid component, the color score should be 1 to 2. The size does not matter here. And there are two categories of unilocular cyst. So for unilocular cyst, we start seeing papillary projection, but that should be less than 4, and the color score does not matter. And any large solid component, it can be of any size and any color score. And one category of solid lesion here, which is having a color score of 2 to 3, at least like to moderate color flow. And it is non-shadowing and a smooth outer contour. Yeah, this is the updated 2022 version, which includes the bilocular cyst, and this is the previous version where the bilocular cyst was not included. Then ultrasound ORATS 5. This is a high risk category. There is a more than 50% risk of malignancy. These are irregular solid lesions. When you say irregular, it's the outer contour of the lesion. And multilocular cyst with worrisome feature, which is a solid component and a higher color score. And presence of ascites and peritoneal nodules. So for a unilocular cyst here, the number of papillary projection is numerous, which means more than or equal to 4. The size or color score does not matter. For a multilocular cyst, it has a solid component with a color score of 3 to 4, which is moderate to very strong flow. A solid lesion with a smooth contour, but with a color score of 4, or an irregular solid lesion. The color score or size does not matter when there's an irregular solid lesion. And additional findings like presence of ascites and peritoneal nodules. So when we see ascites for ORATS category 3 to 5 lesions, it is a worrisome feature. When you see ascites in ORATS category 1 to 2, it could be physiologic as well, and depends on the amount of fluid as well. And other reasons can be sought for as a cause for ascites. And additional is if you see peritoneal nodules, then it is highly concerning for malignancy. So coming to ORAD's MRI system. So MRI, as we said previously, it is an adjunct imaging tool, and it's used to evaluate the ORAD's category 0 lesions, which are like incomplete evaluation or sonographically indeterminate adnexal masses. What are those masses? It's one that has complexity, but even after thorough interrogation, including Doppler, cannot be confidently placed into either the benign or malignant category, or one for which the site of origin cannot be established on ultrasound. So similar to ultrasound, we have the ORATS MRI risk stratification system with a score from 0 to 5. We have the risk categories and an associated positive predictive value for malignancy and descriptors. When compared to the ultrasound ORATS system and MRI, we don't have the management options. There are 2 large trials which are ongoing, and based on that, this will be updated. And so the MRI protocol for adnexal mass characterization at 1.5 or 3 Tesla MRI. So we need a sagittal T2 weighted image without fat saturation and a slice thickness of 4 millimeters or less. Axial T2 weighted image without fat saturation, section thickness of 3 millimeters. The 3 millimeter section thickness is important here and in the post-contrast imaging because it helps in identifying papillary projections, which will not be seen if the slice thickness is more. And the axial in and out of phase image to look for microscopic fat, a DWI to look for the diffusion signal intensity, and ideally we need, a higher B value of about at least 1,000. Then the post-contrast images can be either a dynamic contrast enhanced MRI or a non-dynamic. So the post-contrast dynamic contrast enhanced MRI begins with fat saturation. The scanning is started 30 seconds before contrast injection and it is continued for up to 4 minutes. And for non-dynamic, there's a pre-contrast image and a single post-contrast image performed at 30 to 40 seconds after at the end of contrast injection. So for both post-contrast, the slice thickness should be 3 millimeters or less. So in MR, how we evaluate these lesions. So first we look at the signal intensity of the lesion, homogeneous or heterogeneous. Homogeneous, it has a uniformly similar signal intensity. Heterogeneous, it's very of varying signal intensity. And we describe the signal intensity as hypointense, intermediate, or hyperintense. On T2 weighted imaging, the signal intensity is compared with the iliopsoas muscle for solid lesions and for the fluid component with the CSF or urine. And on T1 weighted images, again, for the solid component, we compare the iliopsoas muscle and the subcutaneous fat. Then if there is a fluid component to the lesion, then we need to analyze the signal intensity of the fluid. It can be simple fluid or non-simple fluid. Simple fluid is one which follows the series of signal intensity on all sequences, hypointense on T1 and hyperintense on T2. And a non-simple fluid can be proteinaceous, endometriotic fluid, hemorrhagic fluid, lipid-containing. Proteinaceous fluid can have variable hypointense signal on T2, and it can be either hypo or hyperintense on T1. It depends on the protein concentration. When we say proteinaceous fluid, this includes pus, mucin, and colloid in ovarian lesions. Endometriotic fluid, again, they're typically hyperintense on T1 weighted images and demonstrate a shading on T2, which is a hypointense or intermediate signal intensity, and it decreases from the superior aspect of the lesion as we go inferior, and that is due to repetitive hemorrhage. Hemorrhagic fluid again can have variable signal intensity depending on the age of hemorrhage. Lipid containing is hyperintense on T1 and T2 with a visible decrease in signal on fat saturated images. One thing is microscopic or intravoxel fat, which is seen as signal dropout on the opposed phase image. This microscopic fat will not be suppressed on the regular fat suppressed images. Then DWI, as I mentioned previously, the signal intensity is compared in relation to urine or CSF on high B value image. So the solid components, again, we're looking for any enhancing tissue within the lesion. And there are different terms to describe the morphology of this solid enhancing component. It can be a nodule, which should be at least 3 millimeters. Papillary when it has a branching architecture, and this can be very well visualized on the T2 weighted images. Irregular septations when the septation has an uneven margin or variable thickness. And solid lesion is it's at least 80% solid tissue. Non-solid component it can be thin or thick, smooth septations or wall, blood clot, non-enhancing debris, fibrin strand, and fat. So on the post-contrast images, how to analyze the post-contrast images? If you see high signal fluid on pre-T1 images, then we need subtraction images to look for any enhancing solid tissue. And on dynamic contrast enhanced imaging, time intensity curves are obtained. To obtain those curves, the solid component and uterus should be viewed on the same slice. It can be in any plane. And an region of interest is placed on the outer myometrium, avoiding myometrial vessels. Another region of interest is placed on the solid tissue, which has the rapid or greatest level of enhancement. And the time intensity curves are generated from this. If the patient has had hysterectomy and the uterus is absent, there are three types of time intensity curves. It can be a low risk, intermediate, or high risk, which we'll see in the next slide. So if the uterus is absent, a low risk curve can be differentiated from an intermediate or high risk curve, but we cannot differentiate the high risk and intermediate curves. So these are the time intensity curves. So the solid black line here represents a myometrium, and the low risk curve has minimal but a gradual increase in enhancement. There's no shoulder or plateau in a low risk curve. An intermediate risk curve shows a steep initial rise, but that is less than the myometrium, has a shoulder and a plateau. High risk curve is one has an initial steep rise in enhancement, but it is greater than the myometrium and also has a plateau and shoulder. So coming to the risk categories, MRI score of 0, similar to ultrasound, is an incomplete exam or a poor quality exam, incompletely imaged lesion, and does not meet the MRI technical requirements. MRI 1, under this category, either it's no ovarian lesion or normal ovaries, or physiologic observations in premenopausal women, which include simple cyst, corpus luteum, and hemorrhagic cysts, which are all less than or equal to 3 centimeters. So in this image, we see the normal ovaries in premenopausal women and postmenopausal women. So normal ovaries on T2 has intermediate signal intensity stroma and follicles which demonstrate T2 hyperintense signal. It can show some degree of diffusion restriction, but no an enhancement of the stroma. In postmenopausal women, the ovaries are atrophic, can be homogeneously solid, or some few small follicles can be seen. And physiologic observation, so we have the axial T2 in the first column, T2 fat suppressed in the second column, fat suppressed T1 in the third, and post-contrast imaging on the fourth. So on the axial T2, this is a hyperintense signal cyst, fat suppressed, again a hyperintense signal cyst, hypointense on T1, and there's no enhancing component within. The wall can show enhancement. Hemorrhagic cyst, so the pre-T1, fat suppressed pre-T1, it is hyperintense. Now T2, the signal intensity can be variable. On this example, it's hyperintense, but there's no enhancement within or on the wall. And a corpus luteum, again, it can have the imaging features of a simple or a hemorrhagic cyst, but it has a thick enhancing wall. ORAD's MRI 2 category, these are almost certainly benign lesions with a positive predictive value of less than 0.5% for malignancy. So this should not have any enhancing solid tissue. So under this category, we have unilocular cyst, any type of fluid content, but there should be no wall enhancement and no enhancing solid tissue. If there is a wall enhancement but then the cyst fluid should be either simple or hemorrhage, endometriotic. And lesion with lipid content, but no enhancing solid tissue. Solid lesion with dark T2 and dark DWI signal. So it should be homogeneously hypointense on T2 and DWI. And enhancement does not matter in this category. Dilated fallopian tube, which is a simple hydrosalpinx, and a parovarian cyst. So for example, we have here a unilocular cyst, any type of fluid. In this lesion, it's a T1 hyperintense, it's hemorrhagic fluid, and there can be mild smooth enhancing wall. And the second example, sorry, is an this is the third one, which is an endometrioma. Again, has a pre-T1 hyperintense signal. It is bright on the non-fat suppressed T1 as well. On T2, it has hypointense signal with the shading, and it has a smooth enhancing wall. And a lesion with lipid content, again, on the fat suppressed T1, you can see the drop in signal compared to the pre-T1 here, but no enhancing solid components. Again, a DWI dark and a T2 dark lesion. So it should be homogeneously dark on the T2 and DWI, and it's hypointense on pre-T1. The enhancement, it can show enhancement, but when you see the homogeneous dark signal on T2 and DWI, then it is categorized as 2. Enhancement does not matter in this condition. And a simple hydrosalpinx, which has a simple fluid signal, hyperintense on T2, hypointense on T1. On fat suppressed pre-T1, it's hypointense, and there can be some wall enhancement with incomplete septations. And a simple para-ovarian cyst, we can see the ovary, it is separate. On the T2, it is bright, T1 hypointense, hypointense on fat suppressed T1, and no enhancement on the post-contrast image. ORAD's MRI category 3. So these lesions have a positive predictive value of approximately 5% for malignancy. So there's a low risk for malignancy. So these are lesions with solid tissue but have a low risk enhancement curve. So if we don't get dynamic enhancement, contrast enhanced MR, we cannot categorize the solid tissue as low risk. Under this category, we include unilocular cyst with proteinaceous, hemorrhagic, or mucinous fluid, smooth enhancing wall, but no enhancing solid tissue. Multilocular cyst, any type of fluid, smooth septal or wall enhancement, but no enhancing solid tissue. Lesion with solid tissue, which has a low time intensity curve on dynamic contrast enhanced MRI. And dilated fallopian tube with non-simple fluid, can be hemorrhagic fluid from endometriosis, for example. Or so we have the examples here. A unilocular cyst, which is hyperintense on T2, hyperintense on T1. On the fat suppressed T1, it is hyperintense, so it's hemorrhagic fluid. And there's wall enhancement on the post-contrast image. And multilocular cyst with differing signal intensity of the fluid content with enhancing septa and wall. And solid lesion, but it is not homogeneously hypointense on T2 or DWI. You can see there's some restricted diffusion, which is heterogeneous. The lesion has a low risk time intensity curve. And enhancement, this is the ROI placed in the myometrium, the outer myometrium, and then in the enhancing portion of the lesion. And a dilated fallopian tube, but it has non-simple fluid, as we can see here on the pre-T1 image, which has a hyperintense signal. And it has enhancing wall and septation, but no enhancing solid tissue. Then ORAD's category 4, so any solid lesion with an intermediate risk time intensity curve. And any lesion with solid tissue that enhances less than or equal to myometrium at 30 to 40 seconds on, so this should be a non-dynamic MRI. And lesion with lipid content which has a large amount of enhancing solid tissue. So for example, we can see the axial T2 image, the solid component here, when we compare with the muscle here, it's greater than the muscle. So this is intermediate signal intensity. Again, on DWI, it is a high signal. And the lesion has an intermediate risk curve. And this is when the ROIs are placed in the enhancing portion of the lesion and the outer myometrium. An additional example, when dynamic contrast enhanced imaging is not obtained, and instead a single post contrast image at 30 to 40 seconds, the enhancement of the solid component should be less than or equal to the myometrium. So here we see the lesion, which is heterogeneous intermediate signal intensity on T2, has diffusion restriction, and on the fat suppressed T1, it's hypointense. And post contrast, the enhancement is less than the myometrium. And a dermoid is a lesion with lipid content, but it has a large amount of enhancing tissue. So one caveat here is dermoids usually have like a Rokitansky nodule, which is a fat-containing component, and that can show minimal enhancement, and that is not considered as solid component. When we see a large amount of enhancing solid tissue associated with the dermoid, then it comes under ORAT's category 4. But there's no consensus on how much should be the large component. It's based on experience. And ORAT's MRI category 5, these are high-risk lesions with 90% positive predictive value for malignancy and have high-risk features like a high-risk time intensity curve, and any lesion on a non-DCE MRI with solid tissue enhancing more than the myometrium, and associated findings of ascites, peritoneal, mesenteric, or omental thickening and nodularity in the presence of an adnexal lesion. So here we have a heterogeneous signal intensity, T2, a lesion with heterogeneous diffusion restriction, and a high signal, high risk time intensity curve. An additional example on a non-DCE MRI, where the enhancement of the lesion is more than the myometrium. So what some causes of misinterpretation will be like when we encounter an adnexal mass, the first important thing is like we need to identify the organ of origin, if it is arising from the ovaries or other structures in the pelvis. So we can trace the gonadal vessels to the lesion, and that means it's ovarian in origin. Or if we are able to identify a claw or beak of ovarian tissue adjacent to the lesion, then it confirms the origin of the lesion as ovarian. If normal ovaries are seen separate from the lesion, then the lesion is not ovarian. Most common lesion when it's mistaken for adnexal lesion is a subserosal fibroid, which arises from the uterus. And in those conditions, we can see bridging vessels between the uterus and the lesion, and that can be a useful imaging finding to identify the organ of origin. So an MR or search pattern, can we first step, like just rule out obvious findings. Like if you see peritoneal disease, adnexal mass, ascites, then automatically it goes to ORATS 5. Peritoneal disease, no adnexal mass, it could be a peritoneal carcinomatosis. We have to look for any other primary. If normal ovary physiologic finding, then ORATS category 1. If we see an adnexal lesion, then it start to look for lipid, solid tissue, number of locules, and the fluid type. Lipid, no enhancing solid tissue, or a Rokitansky nodule which has fat and a minimal enhancing component, then it's dermoid and categorized as ORATS 2. If there is lipid, but there's a large volume enhancing tissue, then it's ORATS 4. There's no lipid and no enhancing solid tissue, but it's homogeneously dark on DWI and T2, then it's ORATS 2. If the enhancing, like the solid component, is not homogeneously dark on T2 or DWI, then we compare the enhancement of the solid component to the myometrium, and it can be further categorized into one of these, like 3, 4, or 5. Then coming to the fluid component here. So a multilocular lesion any fluid signal, it's ORADS3. Unilocular, but the fluid type is simple or endometriotic with the wall without wall enhancement is 2. But unilocular with hemorrhagic or proteinaceous with wall enhancement is MRI3. So now this is just an imaging algorithm, how to go about these lesions. So ultrasound ORADS 0 category needs further evaluation, either a repeat ultrasound or MRI. And when we get MRI, that can be scored based on the lesion characteristics and patient managed further according to the ORAD score. ORADs ultrasound 3, 4, or 5 lesions. If there's any solid lesion or a cystic solid lesion, then MRI can further help to assess for benignity and accurately stratify those lesions into either 2 or 3 or 4 or 5, and further management options can be decided based on the imaging findings. When there is a lesion but unclear lesion origin on ultrasound, again, MRI can help to identify the organ of origin and further stratify the lesion based on the scoring system. So here are a few examples. So we have an ultrasound image here. There's a solid lesion with shadowing, no vascularity. Give us score ultrasound ORAD score of 3 here. And on MRI, there's a homogeneously T2 dark lesion. On the DWI, it's homogeneously dark. Enhancement. So when there's homogeneously dark T2 and dark DWI, the enhancement does not matter. But here it enhances less than the myometrium. So it's a ultrasound ORADS 3, MRI ORADS 2 lesion. And this is an ovarian fibroma. And here, so on this color Doppler image, there is a solid, multilocular, solid cystic lesion. This is a solid component, but very minimal to no vascularity. Via an ORADS 3 lesion. And on MR, this is a non-fat suppressed T1. Here we have the fat suppressed T1. There's drop in signal, no enhancement. This is a dermoid. I'm sorry, it's a ORADS 4 and MR ORADS 2. Another similar lesion, solid cystic mass with minimal vascularity. And on MR, again, it's a solid cystic lesion, but the solid component here is homogeneously dark. It also has dark DWI signal and enhancement. So this is a fibrocystadenophybroma. The ORADS, ultrasound ORADS 4 and MRI ORADS 2. A similar lesion, it's a solid cystic lesion on ultrasound with shadowing. On T2, it has a solid component. It's intermediate signal. It's a mixed signal, actually. There's hypointense intermediate signal as well. On T1, the fluid component is hyperintense. There is a septation here. And this component is, again, isointense to muscle. On post-contrast, there's no enhancement in that component. So that's a clot. There's an enhancing septation. There's enhancement of the wall. So this is a ORADS 4, ultrasound ORADS 4, MR ORADS 3 lesion. It's a multilocular endometrioma. Similar example, this is a dermoid, excuse me, but it has a large amount of solid enhancing component. So this will be categorized as ORADS, MRI ORADS 4 lesion. So this is a dermoid cyst with invasive squamous cell carcinoma. Again, bilateral adnexal like cystic lesions on T2. So these are the small papillary projections. So that's why we need a slice thickness of 3 millimeters or less. And the same lesion like shows diffusion restriction at the region of these papillary projections. There's enhancement, and the time intensity is high risk. I'm sorry, Yeah, intermediate risk time intensity curve, because the initial, it's less than the myometrium. So, or it's a category 4. And this, on ultrasound, is a solid lesion but has irregular outer margins. So it comes under ORAT's ultrasound category 5. Heterogeneous, intermediate to hypointense signal compared to the muscle here on T2. And the post-contrast enhancement is heterogeneous with, it's a low risk time intensity curve. So on ultrasound, it's ORAT's 5. On MR, ORAT's 3, the fibrothecom. In this lesion here, this patient does not have a uterus. So the lesion has, it's higher than muscle. Intermediate signal intensity on T2, diffusion restriction, heterogeneous enhancement on the post-contrast. But it has this guy is like a ORAT's 4 or 5 lesion. Now, when there's no uterus, we cannot differentiate the 4 or 5 category because we don't, we just have a time intensity curve that is intermediate or high risk. So it's ORAT's 4 or 5. And that concludes the presentation, and thank you. Any questions?
Yes, thank you, Dr. Usha. Nice presentation, and we have many questions here. Maybe I will read it for you. We
Yeah.
have the first question is from Dr. Huang Tubuy.
Mhm.
Can I ask a question? So why they do not use CT for the ORAT's classifications?
So CT, CT is once the lesions are stratified based on ultrasound and MRI. And as you know, CT, the soft tissue resolution, CT has good spatial resolution, but the soft tissue characterization is limited on a CT. So once we stratify the lesions and patient is having a high risk lesion, then the patient will be, based on the clinical factors like such as raising tumor markers, and the further imaging will be as per the gyne oncologist referral. So CT will be used once a lesion is established as a high risk lesion for staging and also for like post treatment follow up.
Okay, thank you. And the next questions is there any tips on how to locate the ovaries in pre and postmenopausal women on US and also on MR? Because sometimes we do the MR slice is quite thick, and we learned that it could be located using the ovarian blood vessels. Could you elaborate more about that?
Oh, yeah. So on ultrasound, sometimes it might be difficult. Most of the time on transvaginal, or we can locate the ovaries. But if we are not seeing the ovaries on ultrasound, and next we resort to MR pelvis, again, as we said, we have to trace the gonadal vessels on the right side as we trace from above. Sorry, I don't have images for that. Trace the gonadal vessels toward inferiorly towards the pelvis, and it leads to the ovaries. And the morphology of the ovary in premenopausal women on MRI, we can see the stroma is intermediate signal and presence of follicles.
Okay, and what about, is there any other recommendations of the protocol? How many
So the slice thickness on the, yeah, as mentioned earlier, the slice thickness was mentioned basically for evaluating the lesion characteristics. Basically for the papillary projections, we have 3 millimeters or less. But in premenopausal reproductive age group women, I think we can identify the ovaries. A normal sized ovary can be identified even on a 6 millimeter slice thickness.
Okay. So in postmenopausal women, maybe we can
So
get more.
postmenopausal women, yeah, the ovaries are
3
atrophic.
millimeters is ideally.
Sorry?
In postmenopausal women, maybe we can use the 3 millimeters. on slice thickness?
Yeah, so those sometimes it might be difficult on postmenopausal women as well,
Yeah.
but again, the ovaries are very small, like atrophied. It can be very homogeneously, like hypoechoic. We might not see follicles, but in those cases, if we don't see any obvious adnexal mass, then that is reassuring.
Okay. And there's other questions about the dynamic contrast enhancement. Could we differentiate between the primary ovarian cancer and the metastatic disease in the ovary? Is there any signs of that? And can we utilize or analyze the DCE to differentiate between these two lesions?
Okay, yeah. So the ORADS system was basically developed for patients with the average risk for incidentally detected adnexal lesions. So metastatic lesions in the ovary, again, it have overlapping imaging features with the primary ovarian lesions. But when in patients with no known primary malignancy, we can still apply the ORADS for when we see bilateral adnexal lesions.
Okay,
And further, the next steps would be like oncology referral and then tissue diagnosis. Once if it is going to be metastasis, then we need to search for an additional primary.
yes, because between the primary ovarian cancer and also the metastatic disease have
And also,
overlap
the tumor markers can help.
Yes.
Yeah, CA-125 will be elevated in primary ovarian neoplasms. Metastasis to the ovary more commonly from like GI primaries will have an elevation of CEA levels.
Yes, and in case we cannot do the dynamic contrast MR, do we force to do the non-DCE, the 30 or 40 seconds after the contrast injection, or we can take it lately? Might be about the 60 seconds after the contrast injection. How about that? If we
Yeah,
can
so
do the
yeah, so the ORAD's description was based on like specific imaging protocols. So we need if we are not able to do a DCE MR, I think the 30 to 40 seconds should be obtained for further categorization.
Okay, but can we still use the ORAD's classifications if we do not perform the DCE? Okay,
Yeah,
or
but we need to get the 30 to 40 second single post
okay,
contrast image.
30 until 40 seconds. Okay.
Yeah.
And there's a questions about the ultrasound. When we have to use the transabdominal and when we have to use the endovaginal ultrasound in ORAD's classifications.
So transabdominal imaging, so both can be used because sometimes when the lesion is large and so transvaginal ultrasound gives a good images, good quality images. Transabdominal sometimes may be limited due to like bowel gas, or if there is more subcutaneous fat, then the lesion visualization is compromised. So these are complementary. But transvaginal has a limitation. The field of view is limited. We may not be able to see the entire lesion. So we can try both, like transabdominal and transvaginal, but if it is an incomplete assessment and we are not able to see the typical imaging findings or we are not able to characterize the lesion, then next step would be MRI.
Yes. And other questions is about the ultrasound again. If we do and perform the ultrasounds of the adnexal, when we provide a report, do we provide ORADS or the diagnosis?
So you can we can provide an ORAD score, and when there are like typical features, we can also provide an imaging diagnosis. For example, like if we see a cystic solid mass with papillary projections, we can suggest that it is a serous tumor because the papillary projections are more commonly seen with serous tumors. Or if we see like a typical lesion, like a hemorrhagic cyst or endometrioma, we can still give a ORAD score and then mention the diagnosis as well.
Okay. And what about your opinion on applying the MR and US ORADS in pediatric population?
That I'm not sure because this is described in women of average risk in premenopausal and postmenopausal. I'm not sure about that part. I'll have to look into that one.
Okay, and there's also another questions about the DZE, about the curve, dynamic curve. In 30 and 40 seconds, we have a peak contrast, and after that, the intensity of the enhancement wouldn't change. Why we forced to do the MR at 30 until 40 seconds after the injections? Dr. Shia?
So the dynamic is different and the 30 to 40 second is different. For the dynamic MR, the imaging starts like 30 seconds before the injection of contrast and it is continued for up to 4 minutes. We do that because sometimes we may need subtraction images, so that's why we start before like pre-contrast and continue with a temporal resolution of at least 15 seconds, so we are able to get the accurate curves. And the non-dynamic is like just a one time, like a one post-contrast image. And some lesions, for example, a fibroma, may not show any early enhancement. Like fibrous tissue always show like delayed enhancement, but malignant tissues will have an early enhancement. I'm not sure if I answered this question correctly. Are you?
Yes, I think it's already been answered by you. Okay. Okay, all the attendees, is there any other questions? Okay, I think that will be our last questions for the discussions. Dr. Usha, thank you so much for the interesting and also comprehensive talk and also the discussions, Dr. Usha. And now we will back to GP.
Hey, thank you so
Yes.
much.
Okay.
Thanks,
Thank you.
Dr. Sridhar, for moderating this session. Thank you so much. And Dr. Usha, thank you so much for an excellent talk, very illustrative, very educative. Thank you so much. So the next, for the attendees, can we have the question, please, the quiz question? So the quiz question should be a cakewalk for you guys after such a wonderful lecture here. So, all right, you guys get 2 minutes to answer this. Again, before you please make sure you scan the QR code and answer the question. Please do not post your answers on the Q&A box or the chat box, please. You scan this QR code using your mobile device, then you get an option to answer the question there. Please answer the question there. So this is a 22-year-old woman with a left pelvic pain. What ORATS is this? You see the image there? This is an ultrasound image, 4 centimeter lesion right there. Is it ORATS 0, 1, 2, 3, or 4? You have A, B, C, D, E, 5 options there. Make sure you scan the QR code and answer the questions. You've got 2 minutes to answer this. Thirty seconds up. This is a 22-year-old woman with left pelvic pain. What is the ORATS on this image? Last 60 seconds. Last 30 seconds. Last 10 seconds. All right, done. All right, can we go to the answer, please? All right, so the answer is option C. It's ORATS2 lesion. As you can see here, this color Doppler ultrasound image, which shows a 4 centimeter left ovarian avascular cyst containing retractile clots. Those are the arrows there, which evident by the straight margin and reticular pattern consistent with hemorrhagic cyst. So this is an hemorrhagic cyst ultrasound image. So that becomes a ORATS2 lesion. All right, thank you everyone for answering this quiz question. So now can we go to the evaluation, please? Can we get the QR code for evaluation? All right, so please make sure you use the QR code and evaluate this session, and the certificates will be issued only to those who complete the evaluation. So please complete the evaluation. And also, a change in the schedule of our next session, which was supposed to be on October 6th, but we have the next session on next Sunday, which is September 29th. So that is next Sunday, same time at 9 a.m. Eastern US time. And this will be the hot topic again. This would be AI in radiology, the most talked about topic right now, AI in radiology. And the speaker would be Dr. Albert Cho. Dr. Albert Cho is he's has got PhD in bioengineering, and also he's a radiologist. He's professor at UCSD in California. He is also an owner, co-founder of Arteries. That's one of the companies which started a 4D MRI flow. So he's going to be talking about AI in radiology. That is next Sunday, September 29th at same time. So thank you so much. Thank you all the attendees for attending this wonderful session. Thank you so much, Dr. Usha, Dr. Sirigan for getting this session done. Yes?
Oh, can I say something?
Absolutely, please.
Sure. Yeah, sorry. I have to add something regarding the last Q&A question. I'm sorry if I was not clear in the protocol. So either you get dynamic contrast enhanced MRI. If we are not able to get dynamic, then in the non-dynamic protocol, it is a single post-contrast image at 30 to 40 seconds. So we don't have to get both for the same patient.
Okay. Okay, thank you so much for clarifying that. I hope that helps. Thank you so much, Dr. Usha. And also want to thank IT team for such a wonderful job on this, and everyone in the panelist. Thank you so much. Dr. Nat, do you have any announcements? Are we done for this session? Okay. All right. Thank you. Thank you, everyone. You all have a wonderful day. Thanks.